Shamsuddin Fakhir, pediatrician from Cypress. As you can see, the first two names on the slides are very, very difficult to pronounce. Anybody who can pronounce it correctly will get a prize at the end of the day. This is a slide which will go into archives because this will be history. There are no regions now. But I'm from Cypress Health, and Cypress Health has done something marvelous in the last few years in terms of quality improvement. Ladies and gentlemen, quality is continuous. All the time we talk about quality, we talk about improvement, we talk about patient safety, and clinical pathway is one way of improving quality of care. And that was the main question to us most of the time in Cypress, because we have tons of pathways, something lying somewhere in the archives, in the electronic medical records or in the files, but nobody was using it. So we are just concerned about what is the reason why when we invest so much of time and energy and nobody is interested to use those pathways. So we selected a clinical condition where there was a lot of variation among hospitals, among provinces, and among countries, and that was acute bronchiolitis in children. The intention of the project was to reduce the use of chest X-ray and respiratory swab by 50% by the end of 2017. And the reason for action was there was significant variation in the management of acute bronchiolitis in children. There was a lot of use of chest X-ray and respiratory swabs in the management. Physicians were not using evidence-based clinical pathways. There were barriers in using clinical pathways, and there was lack of organizational support. So that is the journey that we started to use acute bronchiolitis pathways. We aimed at 50% reduction in chest X-ray and respiratory swabs. We developed locally owned bronchiolitis order set, intensive engagement, education and training, and chart review weekly. Physician order set went through 4 PDSA cycles, and there was a definite ownership and willingness to use. And finally, changes implemented. Physician order set has wide acceptability, and 3 patients in the month of October did not have chest X-rays and respiratory swab asked for the management of bronchiolitis. Now, one of the things which opened my eye was when I was talking about acute bronchiolitis to a few family practitioners who were working in the ER. 2 of the young family practitioners, they came to me and they said that, Dr. Fakhir, you are sitting at 2 o'clock, you are sleeping at 2 o'clock in the night, and you are asking me to manage a 2-month-old baby at 2 o'clock in the night. I have just graduated. It's been 6 months that I have been working in the ER. A baby who has got a respiratory rate of 80 per minute, look very, very sick, and you are asking me not to do chest X-ray, not to do CBC, and not to send swabs. And that was an eye-opener. I thought that perhaps he's right, because he has not been exposed to. CPS has made guidelines. They have just posted it. But they have not invested anything into using those guidelines and using those clinical pathways by those who are working with the end users. And that was a thing that I thought that perhaps I have to invest my time with these young physicians. And I said that, okay, once you get to acute bronchiolitis, you don't have to see that what the time. You call me. I'll come. I'll sit with you. I will invest my time, and we'll let you know how can we manage acute bronchiolitis in young children without asking chest X-rays and swabs. And I will show you the same child 24 to 48 hours later, and then perhaps you will get some confidence in managing those young kids who initially looked very sick but ultimately improved. So clinical pathways guidelines take up to 3 years to be fully implemented, and that we forget most of the time when we have the clinical pathways. We just sit in the air-conditioned conference room, we make the pathways, and we send it for implementation, but we forget who is going to use it, what's the situation there. Even small changes may have a positive impact, especially if the change involves an action that is repeated often, and that's what exactly I did. And I did it to an extent that now once I go to the ED, the first thing the nurses tell me is there is no acute bronchiolitis. So this is the step that we took. February 2017, physicians were asking, where is the bronchiolitis pathways? And I talked to them. April 2017, no, I cannot use it. Did you involve me? I said that I did not involve you. Please come and sit with us. We will see that what you want. And then August 2017, thank you for your for the engagement. Can we change the pathway into physician order set? They said that I cannot use this pathway. It's too cumbersome. I said, okay, we'll make it into physician order set. It was too difficult to change the pathway into physician order set because the management of acute bronchiolitis is not on the standard lines. You know, there are no medications involved. It's basically a conservative management. In September 2017, they say, I feel very confident. Now I'll use this. Thank you for involving me. So clinical pathways assure quality and safety and efficiency in the much needed coordination in a busy clinical setting. They improve patient care, consistency in the management so that both physician and patient feel confident. Achievements, development of a locally owned clinical pathway in physician order set. Please don't have any clinical pathways unless it has been owned locally. You have to modify it, keeping in mind the local situations, local scenarios, local stewardship, local expertise. You have to have engagement of all the care stakeholders. Without that, your clinical pathway is not going to succeed. Motivation of staff is very important. I was there for 4 hours, 5 hours, 6 hours with the physician just to see that he gets some confidence. Awareness and knowledge about clinical pathways, acceptance and change in beliefs and behavior. Unless you do that, clinical pathway is not going to succeed. We created an environment of trust and mutual respect, professional autonomy, improved communication, and enhanced organizational support. We have yet to harvest. The data will come by the end of this year and April next year. But 3 children, you know, which we saw in the month of October, they didn't have any chest X-ray or respiratory swab done. You know, acute bronchiolitis is a seasonal disease. The patient will start coming from November onwards. So the disease season is from November to April. That was our team. Thank you.